All right, good afternoon and welcome to the Immune Deficiency Foundation's Lunch and Learn series. Today's program will explore Hyper IgE syndrome with Dr. Alexandra Freeman. My name is Emma Mertens and I'm the Program Manager of Community Relations at IDF. On behalf of all of us at the Immune Deficiency Foundation, I'd like to thank you for joining us today for this Lunch and Learn. We are excited to host this webinar for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your journey. Today's Lunch and Learn is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. Before we begin, I would like to point out a few housekeeping items to keep in mind for today's Lunch and Learn. This afternoon, we are using the Zoom webinar feature. Attendees should be able to see the slides and our panelists and be able to hear myself and our panelists speak. Attendees will not be able to activate their video camera or their microphone. There will be the opportunity for questions after the presentation. You are welcome to submit any questions you have for our presenters as you think of them throughout the session. Please type them in the Q&A box in the control panel on your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer. Please remember that information presented during this forum is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. To learn about IDF and explore our resources, please visit our website at www.primaryimmune.org. The website offers a wide variety of online and printable resources for anyone seeking information or support for PI. This includes the Patient and Family Handbook for Primary Immunodeficiency Diseases, which you'll see there on the left, which has a chapter dedicated to Hyper IgE. We can also help you find a PI specialist in your area with the Clinician Finder. Visit the IDF Resource Center where you can find all IDF publications, videos, news, and more. We also encourage you to check out IDF's Hyper IgE website, which can be found by visiting primaryimmune.org and searching for Hyper IgE in the search bar, or by visiting this link on your screen. The website offers information on symptoms, diagnosis, and treatment for Hyper IgE, and you can also find videos of past presentations on this topic and hear real stories from actual patients. IDF also offers monthly programming and events. In addition to our Lunch and Learns, we host 2 IDF forums a month. We also have Get Connected groups, peer support, Ask IDF, and our annual PI conference, which we just wrapped up at the beginning of the month. And now I am so pleased to introduce our presenter for today. Dr. Alexandra Freeman is a pediatric infectious diseases clinician and the director of the Primary Immune Deficiency Clinic at the National Institute of Allergy and Infectious Diseases at NIH. Welcome, Dr. Freeman.
Thank you so much. And really happy to be here. Thank you for the invitation to speak. So I will share my slides. So I'll be talking today about Hyper IgE syndromes, and I'm going to focus mostly on one Hyper IgE syndrome caused by mutations in STAT3. And just to start, as was introduced, I'm here at NIH. So here's a picture of our hospital. And hopefully you can see my pointer where we see pediatric patients down here on the first floor and our adult inpatients on the 5th floor. And then the taller building is where our clinic is. Okay, so you know, when we say Hyper IgE syndromes, we're referring to kind of a group really of distinct diseases that share kind of these 3 features of having a high serum IgE, which is one of the antibodies that's in the blood, eczema, and recurrent skin and lung infections. And over the years, there's actually been multiple genetic etiologies found to cause a Hyper IgE syndrome. And each of them has a little bit of a unique kind of flavor to it. So today we'll be talking about, oopsie, I don't know why it started going on its own here. Oops. Okay, sorry about that. Seems very sensitive today. So today we're going to be talking about STAT3 mutations causing hyper IgE syndrome, which some people refer to as Job syndrome. But I listed some of the others here, as well as some of the features that they have in common. For instance, those with the STAT3 mutations also have connective tissue abnormalities, which such as flexible joints or bone issues. Whereas other types of hyper IgE syndrome have other features such as persistent viral infections that we see in DOCK8 deficiency, or sometimes neurologic defects that we see with PGM3 deficiency. Anyways, our hope is through studying each of these distinct diseases is that we can understand then not only more about the hyper IgE syndromes and how to take care of individuals with those and why they occur from these mutations, but also then to generalize to the general population. Well, if a STAT3 mutation is causing eczema, well, how is that related also to the general population with eczema? So we're seeing individuals for those two reasons. And at the NIH, we have a protocol where we see individuals with hyper IgE syndromes, most frequently with those with STAT3 mutations, DOCK8 deficiency, as well as some of these other genetic etiologies that I put up here above, to not only kind of study them and take care of people with those, because we feel like through seeing individuals with these diseases, we really begin to understand them to try to kind of answer the broader questions. And I'll just point out also that at NIH, we contributed to the definition, the genetic definition of multiple of these, including that of STAT3, urban, CARD11, CARD14, DOCK8, and PGM3 deficiency. So we'll get started now about STAT3 deficient hyper IgE syndrome. So this was initially described in the 1960s. This was the initial description as Job syndrome. And it was named actually after Job, the biblical Job, from this quote. So Satan went forth from the presence of the Lord and smote Job with sore boils from the sole of his foot to his crown, because a couple sisters were being followed at that time up in Washington State. And the doctors were remarking how they kept having recurrent boils. And I think the story really is that, it was some of the resident doctors that were taking care of them said, okay, for rounds today, we have to come up with a name for this disease that these two individuals have. And they said, let's call it Job syndrome because of this. And then in the early 1970s, IgE was identified. And it was put together actually by Becky Buckley down at Duke as hyper IgE recurrent infection syndrome. And then it was later in 2007 that the genetic etiology of STAT3 was identified, and that kind of narrowed it down to STAT3 deficient hyper IgE syndrome, or, often we'll just say hyper IgE syndrome. So I'm first going to talk about some of the clinical features, and then I'll talk a little bit about kind of our understanding about the disease. And then I'll talk a little bit about treatment, and then finally some of the research that's ongoing about this disease. So the initial presentation of this disease is usually right in the newborn period. So either at birth or within the first couple of weeks of life, babies usually have a rash, and it looks like eczema, except it comes up a little bit earlier than babies that just have typical eczema, which is usually around 2 months of age or so. And it's a little bit more centered on the face. So you can see the little baby here with the crusting around the ears, and the eczema that we see that persists through childhood and often through early adulthood or through adulthood. The ears and kind of crusting behind the ears is one of the main areas where we see a lot of disease. The eczema in this disease is usually driven by Staph aureus, that bacteria, colonization or infection. And we found if we can do pretty well controlling Staph aureus, and I'll talk more about treatment later on, but if we can minimize the amount of that staph bacteria in the skin, the eczema usually becomes fairly mild. And in many of our adults, actually, the eczema is barely there at all or not there at all. So that is good over time. And then the other thing is with the skin that usually really early in life, individuals have recurrent boils, such as the description that we talked about. So, and here's an example underneath someone's arm of one of these boils. And what's unique about these is they aren't always painful. So sometimes they are, and sometimes they're hot and they're like a boil that anyone else might have. But sometimes they lack some of those cardinal signs of inflammation that we think about with an abscess, that where it's usually painful and hot and people have a fever. And if you open them up, there's lots of pus inside, and often these do need to be drained. And we found over kind of recent years, if we can, again, control the amount of staph on the skin, that these are usually pretty infrequent. I would say, we can have a whole year basically go by without one of our patients having a trouble with a boil. The other things that happen are recurrent pneumonias, and these usually start early in life, in the first few years of life. And the bacteria that cause them are, number one is probably Staph aureus, and we see some other bacteria too, like streps. Now, this is a chest CT, and I don't expect those of you listening to know exactly how to read chest CT, but I thought I would just describe it a little bit just to tell the kind of story about how the pneumonias can present with this disease. So when you look at a chest CT, the individual is lying on their back and we're standing at the feet looking towards the head. So I think you all should be able to see my arrow. So this is the left lung and this is the right lung, and this is that individual's heart. And air is black, so you want a lot of air in the lung, and you want kind of this lacy appearance of all the separations as the branches of the airways go through the lungs. And then you can see over here, there's a big splotchy white thing that's there with some white patches in the middle, black patches in the middle of air. And that is a big pneumonia. And this individual this was a staph pneumonia. This was actually a MRSA pneumonia. So what's unusual in this disease is that if other people have a MRSA pneumonia or a staph pneumonia, you feel miserable really, really quickly with a high fever and usually chills, really like unable to get up, kind of sick. And this individual, when she had this pneumonia, she actually sent us this CAT scan. She got it over a lunch break at work, and she said, I have pneumonia, but I'm really busy at work right now. And I was like, you need to get seen. So she actually flew up and we took care of her. But those first several days of illness, people with hyper IgE syndrome often have less of those kind of typical findings. They might not have as much fever. They may not have a lot of the other kind of symptoms of being super achy and super miserable, but over time, those will be there. And their blood work also might not initially show a lot of those usual signs of inflammation. Like we look at white blood cell counts for people when we look for things like pneumonias, and an otherwise healthy individual, you'd expect it to be really, really high. And here it might not even be that different than baseline, but it's a pretty significant pneumonia. And you can see, with these kind of little islands that look like they're appearing in the middle, that's because the bacteria is actually eating away at the lung inside. So we'll talk more about that later. The other thing we see in this disease in terms of infections is yeast infections. So here's a picture of someone who has yeast infections of her fingernails. And we also see that, for instance, in the mouth, causing thrush or vaginal yeast infections as well. Now, one of the things that's unique about hyper IgE syndrome compared to some of the primary immune deficiencies, some of them have other features, is that there's a lot of things that don't involve the immune system too. So the bones are involved, the joints, the teeth, blood vessels, it is really a multi-system disease. So the joints are often flexible. So people are kind of double jointed, and the bones, they usually fracture pretty easily. So you can break your bones pretty easily. And about 3/4 of our patients have some degree of scoliosis. So this is an x-ray, and that's looking at the spine of the x-ray, and it should be straight. And you can see that there's a little bit of a wiggle to it. So that's scoliosis. And then we look at brain MRIs of our patients, and sometimes the way the shape of the skull is, you can see the little bump here on top. That is from craniosynostosis, is the way the skull kind of fuses together, can be a little bit different. Also on the brain MRI, you can see over here, we'll see these little white spots that are not normal. So you just have to trust me with that. I won't go through the whole thing like I did for the chest CT, but we think this is related to small blood vessels in the brain that might be causing these little changes over time, although our patients don't have neurologic issues related to this. Baby teeth in this disease often don't fall out. So most of our patients have to have at least some of their baby teeth pulled out so the secondary teeth can come in. So you can see in the picture, there's some of these people have double rows of teeth. And then blood vessels sometimes can have some swelling, some dilation. And where the arrow is pointing, this is actually an angiogram looking at the arteries of someone, like coronary arteries, the arteries that perfuse the heart. And you can see here, the artery is kind of swollen in that one area. People also talk about in hyper IgE syndrome that there can be a characteristic facial appearance. It's not always super obvious, but people talk about the skin being a little bit more coarse. and the nose having a little bit more fleshy appearance, and a little bit of an asymmetric appearance. But you can see in the picture, like the two women in the front here, sometimes, individuals kind of can look a little bit more like each other even than some of their siblings, for instance. And in our waiting room, sometimes people can, I guess, not anymore with masks, but pick each other out. Another thing we sometimes see is problems of the intestines or the esophagus. So I realize that some of my slides, I switched to the non-medical. So some of this has a little bit of medical terms, but sorry about that. But sometimes we see that the swallowing's not totally smooth. Like sometimes people feel like food is getting stuck. That's what that dysphagia is, or they have reflux. Every once in a while, luckily this is pretty infrequent, but sometimes we can see that a hole can emerge in the intestines, a perforation of the colon or the cecum, or sometimes we'll see diverticulitis. So when I started working at NIH, which was with this population, this was in 2005, we were really confused about what actually caused this. This is when the genes were being discovered, before that time and some after that time, for a lot of the primary immune deficiencies. And this was a big mystery because we're like, why, what gene is going to control both things like staph as well as teeth and bones? And then, so in 2007, when I was at, so here, obviously, we figured out that it was mutations in a gene called STAT3. And my next slide, I'll describe a little bit what that is. So that was described here at NIH as well as in Japan. And there I am. So this is kind of what STAT3 does. And I'll walk you through this because I realize this is slightly complicated. So this line you have to prove, believe is supposed to be a cell, this black line right here. So STAT3, STAT3, so it stands for signal transduction. So how do signals get across from cell to cell? And then the other part, the AT, is activation of transcription. So that's how proteins are made. We can all remember back to our science classes. So cytokines are little inflammatory molecules that are secreted by cells, and it's how cells talk to each other. So a bunch of them, bind on their receptor and then go through kind of a cascade, a signaling cascade that involves STAT3. And then STAT3, once it's inside the cell and kind of activated by this pathway, will then kind of pair up with another STAT3, and it goes into the nucleus and turns on and off lots of genes. And what's important here is that STAT3 is expressed all over the body, and it's involved in, lots of different things. Like it's involved in wound healing and blood vessels and cancer. But it's expressed all throughout the body, and that's why so many different things are involved in this disease. But again, it's really the signal transduction part is what's important here. It's like how cells talk to each other. And those individuals that have this disease have less of the STAT3 function. So I'll talk a teeny bit about kind of some of the initial understanding that we had about, why people get infections. So one of the things we learned about after we learned about the gene being STAT3 is that STAT3 is involved in one of the types of white blood cells that are called Th17 cells or Th17 lymphocytes, and they're involved in the immunity, what we call mucosal immunity or epithelial immunity. So it's basically the first part of your immune system that meets the outside world. So it's the immune system that affects the skin and the lung and the nose and the mouth. And that's where we see the infections. So there's some immune deficiencies where you'll get more frequently, for instance, a liver abscess or a bone infection. And although sometimes we'll see those things, it's really rare. It's really a problem in the immune system of where the body meets the outside world. So for instance, the fingernails, having the candida, the yeast that we see there. And that's because we realize that these individuals do not make these type of lymphocytes that are called Th17 cells. So this is just a graph of that when we first figured that out, because we knew that then STAT3 was involved in how those lymphocytes are made. So this is a graph looking at the little dots, the green dots being healthy individuals, the red dots being those with the STAT3 mutations, and blue dots being people that had high IgE for other reasons. And there's kind of a lack of this, and that's what's contributing again to that epithelial or mucosal immunity. The other thing we realize is that people don't have as much of the memory of the lymphocytes. So individuals with hyper IgE syndrome, if they see a viral infection, for instance, usually do okay. It's not so much a problem controlling viruses as much as it is controlling certain bacteria and yeast, but then they don't have that memory, that long-term memory against viruses. So kind of a classic disease to think about this in is chickenpox. So chickenpox, if you get chickenpox or the vaccine when you're little, then, that virus lives in your body for the rest of your life. And you're relying on the memory of your T lymphocytes to kind of keep that in check. So, and if you don't keep that in check as well, then that virus can emerge and it causes something called shingles. So shingles is like one stripe of chickenpox. So here is a boy with hyper IgE syndrome and has this one stripe of shingles. And, shingles can be very difficult in people that are immune deficient, but here it's not really different than otherwise healthy people that get shingles. And, usually we can pick it up quickly and put people on medicine and then it's okay again. And we haven't had kind of lasting issues related to shingles, but it's because of that lack of memory that we sometimes see this at a younger age than in other people. So usually shingles is something you see in more elderly people, or not elderly, but people that are like 60s, 70s, 80s, 90s. And here we can sometimes see it in younger individuals. The B lymphocytes, so B lymphocytes are the lymphocytes that make antibodies, and they also don't have good memory. And this is why some people end up on immune globulin replacement therapy. So that varies from patient to patient that we see, but some of our patients, they're just not good at remembering those vaccine responses. And that's because of the lack of memory there. One thing that was also interesting that we realized over the years is that our patients have food allergies and they can have anaphylaxis, but we don't see quite as much as we did in our other patients that were coming in with super high IgEs for other reasons. So again, IgE is an antibody, and the IgE antibodies are related often to allergy. So if you're allergic to a peanut, then you make an IgE against that peanut, and that can lead to a bad allergic reaction or anaphylaxis if you eat a peanut. So what we realized though was, although our patients were allergic to things like that, we didn't see anaphylaxis as much. And compared to other individuals with really high IgEs, we didn't quite see as much food allergies. So in this kind of bar graph here on the left, we look at healthy individuals, and then we looked at the patients with the STAT3 changes, and then we looked at others with really high IgE. You can see that the amount of food allergy, so this graph is looking at the amount of food allergy, is less than the others. And then when we looked at anaphylaxis, it was actually a lot less. So we did some experiments to try to understand that. And what we realized is the mast cells, which are the cells that kind of explode to give you those hives and give you an anaphylactic reaction, that those weren't as twitchy as they were in otherwise healthy people. So in that way, the STAT3 is actually, the less activity of the STAT3 was actually preventing that really high IgE to cause such severe allergic reactions. But STAT3, as I said, is a major way how cells talk to each other. So understanding everything in this disease, why are the joints so kind of flexible, or why do the bones break more easily, or why do the baby teeth not fall out, has been really hard because STAT3 is just connected to so many different things. So it's been very confusing for us to understand. So one of the things I thought I'd talk about is some of the work we've done about how tissues heal. So one of the things that we worry about in with STAT3 mutations is that when a lung gets an infection, so for instance, if the lung has a bacterial infection, like a staph infection, when it heals from that infection, there is often left a hole or pneumatocele afterwards. So in this chest CT, where the pink arrow is, you can see this big kind of circular ball that's there of air. And that's what we call pneumatocele. That's a leftover pocket of air where lung tissue used to be. And then that little white smudge in the bottom is an aspergillus infection that moved in there. So we think that is because the lungs don't heal well after infection, that you're left with these holes. And then infections like aspergillus that we really, are a little bit more difficult to treat can move in there and cause some problems. We also see bronchiectasis, which is some kind of widening of the airways from inflammation that can develop as well. And also going to that concern about how the lungs heal was when our patients would have lung surgeries, some of them, about half of them did okay. And then about half of them would end up with some trouble healing, and it would take, maybe have a chest tube in place for a couple months afterwards while the lung would heal. So here's an individual who had a big infection inside one of those pneumatoceles, and the local hospital had removed that. And then this little circle-y thing right there is actually a chest tube that was left in place then for, several months as the lungs kind of slowly healed. So when we thought about the healing, we also started thinking, okay, this is probably then relates to why we see, these aneurysms, kind of these widening of some of the blood vessels over time. And here at NIH, we do screen for these to make sure that there's, none of these blood vessel changes in the heart or in the brain to, because otherwise we'll try to think about therapies to prevent them from causing any problems. So this is kind of a from one of the labs that I collaborate with at NIH and the National Heart, Lung, Blood Institute. We started looking a little bit more at the tissue remodeling. So I just thought I would share kind of one of these pictures, again, showing a little bit of the science side of what happens at these places. So we started looking about, what is going on about the tissue remodeling. And this is a little bit of there's a lot of information in the slide, but I'm just going to give you the gist of this. So if you look at this graph, which is fibroblasts, and you look at the bars, the first 3 bars for each of these, for MMP1, MMP3, MMP9, and KDR, the first 3 bars are skin biopsies that we took from healthy controls. And then from that, we grew out fibroblasts, which are some of the, they're kind of connective tissue cells that live in the skin and kind of other parts of your body and are involved in tissue healing. And then the second 3 bars for each of these are ones that we took from people with Hyper IgE syndrome from STAT3 mutation. And then we stimulated this with kind of gave it one of those inflammatory cytokines, TNF alpha, which is to give it a little bit of inflammation to then trigger there to be some tissue remodeling. In these MMPs, MMP139, these are matrix metalloproteinases that are involved in tissue remodeling. And this one is KDR is involved in kind of blood vessel responses. So what you see here is, what you should see is after this response, you'd see kind of the tissue, those cells go to work at kind of remodeling the tissue. And you can see that the fibroblasts from those with the STAT3 mutations are a little bit pokey, and they're not kind of rising up to the occasion to go in there and start cleaning up things and remodeling the tissues. So now the question is, what do we do about that? And those are kind of ongoing studies to try to understand, because we'd like people to be able to remodel their tissues. So for instance, if we do it in lung surgery, that we won't worry about the healing associated with that. On the right here, now these are, again, those skin cells that we took, and then we turn them into these kind of a stem cell type tissue where you can actually get like a little bit of the connective tissue cell and blood vessel cell. And you can see here the control, and you can see how pink and red it looks because these are the blood vessel cells growing. And then the one from the skin biopsy with the STAT3 mutation looks pale. So from this, we realized that, the blood vessel growth isn't quite normal, and that's probably explaining some of the reason for some of the findings that we see. So again, this is just kind of giving us some clues about now what should we do to try to improve these findings. So kind of going along with that, I think over the years, we've done a much better job in terms of treating infections associated with this disease and improving long-term survival. The amount of decades people live has gone way up in the years I've been here. And also the kind of earlier diagnosis is really changing the natural history of the disease. We've had a bunch of patients now that were diagnosed really within the first month or 2 of life, usually because of family history. And, it's such a different disease for those people. But, as people are then, doing better from the infections, we see more orthopedic events. You can see here, this is a hip replacement in an individual, or we worry about the blood vessel things, like maybe we'll see someone who has intestine bleed, for instance. So, I feel like now, we really need to start focusing some of the research on kind of, this tissue remodeling that's leading to the orthopedic events and the vascular events, how to make people heal from the normal wear and tear that we all have over time. So, and unfortunately, I think a lot of us that study this disease are infectious disease or immunologists. So now we need to get those other people more involved. So how do we diagnose hyper IgE syndrome? So it's genetic testing. for those with compatible symptoms. So I've been talking just about STAT3 today. And for those individuals, there's both the infections, the eczema, plus the connective tissues, such as the flexible joints or the bone issues. If we see those different things, we do the genetic testing for STAT3. And these days, people will often do kind of a panel that either is just for different types of hyper IgE syndromes or for all sorts of primary immune deficiencies, or they just look at everything genetically. Back in the day, before we really had the diagnosis, people used a scoring system. We don't use that quite as much now, but that's usually how the diagnosis is made. And then what do we do to approach care for individuals with this? So, most of the time it's supportive. So, we really worry about the staph infections causing pneumonias, not so much, we don't want people to have a boil, but a boil we can deal with. What we don't want is people to have a staph pneumonia and end up with a new, big hole in their lung. So we usually use some sort of suppressive antibiotic to try to prevent staph infections. One of the ones we use commonly is trimethoprim sulfa or Bactrim. And depending on, what's going on with that individual, sometimes we'll use antifungals. So for instance, if there is a big hole in the lung, we'll usually use some sort of antifungal to prevent mold infections inside the pneumatocele. Another thing that I always try to bring up with people is that there's certain parts of our country, I'm not sure if everyone here is in the United States or other places as well, but in the southwest of the United States, there's a fungus in the soil called coccidioides, and that can actually cause meningitis in people with hyper IgE syndrome. So, we try to have people on an antifungal if they're traveling to that area as well, or if you're living in that, I have my patients taking an antifungal each day. The other thing we do is to prevent staph on the skin is using antiseptics, especially in kids who have more trouble with eczema. We'll have them take dilute bleach baths, which is usually about half a cup of bleach to a cup of bleach in a tub. You soak in that for 15 minutes and wash it off, or chlorhexidine, which is Hibiclens, or swimming in chlorinated water. And that really decreases the amount of staph on the skin and helps to control the eczema. In recent years, dupilumab is actually a monoclonal antibody that's been approved for eczema. And more of our patients have been using that. It's a shot that's given every 2 weeks and having success for that as well for eczema. We consider immune globulin supplementation. So we usually look at the antibody responses, and some patients think it helps and some people don't think it helps as much. But sometimes we will use immune globulin either as IV IgE or subcutaneous IgG. We think a lot about everything else, the bones, the teeth. When people come for their annual visit here, especially in the kids, we really worry about the making sure that the baby teeth come out at the right time so that the secondary teeth can come in then normally, and then the bones, because fractures are increased, we take a look at the vitamin D and we try to prevent other causes of having thinner bones. We try to educate people about the low suspicion for infection, that not all the signs are what people will expect or what their doctors might expect in terms of fever and stuff. And kind of in more recent years, bone marrow transplant has become a slightly bigger consideration. I would say it's kind of going up and down. But I was just going to give a couple slides just to talk about that, just because I feel like people have been talking about it more for hyper IgE syndrome. But first, let's talk about dupilumab. That's this monoclonal antibody. I know a bunch of my patients have been using it and talking to people about it. So it's approved now for eczema above 6 months old, or asthma for a little bit older, or eosinophilic esophagitis or sinusitis with polyps. Most of our patients, we've used it for eczema, and that's where we've seen kind of our bigger successes. It's an injection that comes as it comes with a pre-filled kind of pen injection. It's given subcutaneously under the skin every 2 weeks. I know it can hurt when it goes in. I had a younger patient here this week telling me how much it does hurt. Warming up to room temperature can help, but I think it still often hurts. It's usually well tolerated. It's not always perfect, but most of the time it's well tolerated. But besides the pain, there can be conjunctivitis. I haven't seen that. Sometimes you'll see some blood changes right after it starts in the eosinophils. And over time, though, we do see the IgE come way down. I mean, we don't really care what the IgE level is, but it is interesting on this medicine. It will come down from thousands to hundreds usually. Okay, and then I'll talk a little bit about bone marrow transplant. So this is kind of some of the quick history of papers written about bone marrow transplant. There's been a little bit more recently, but back in the year 2000, these authors here wrote a paper that says bone marrow transplant doesn't correct the hyper IgE syndrome. This is a group out of Newcastle in the UK. And I happened to be at a meeting last week and met with Dr. Gennery that's here. So they had transplanted a child with severe eczema and had recurrent lung infections, and they thought it did not work. Now, about 10 years later, this paper below was published. Now, this is out of a group from Greece. And, you know, no one had really done transplants because of the paper on top. So this group on the bottom did 2 transplants because of patients that have lymphoma. There is a slight increase in lymphoma for hyper IgE syndrome. And they had transplanted these people and they said, everything got better, you know. So not only did they see some of the things I talked about, like those Th17 cells, those immunologic markers got better, but they also saw, you know, the infections were better, the eczema was better. They said the bones were better, some of the facial changes were better. Some of those things I don't quite believe, but anyways, so it changed though kind of people's approach. And we started thinking, well, you know, transplant's not going to correct everything for this disease, but maybe it corrects enough to think about it a little bit more. So what is a bone marrow transplant? And kind of what is your best approach? So a bone marrow transplant is when you replace the white blood cells, the red blood cells, and the platelets. So those are the things that are made in the bone marrow. So first you have to choose who is your best donor. So for that, you have to, you look at some of the white blood cell typing. And, you know, the preference is always if you have a matched sibling, but then you can also use people from, there's banks, matched unrelated donors, or sometimes like a half matched donor, which could be, for instance, a parent or a sibling. But, you know, it does matter a little bit for this disease in which transplant is a little more controversial. When we think about transplant, you know, I think about more if someone might have a matched sibling. And then, you know, you try to be in as good health as possible going into the transplant because, you know, it is kind of a risky procedure to go through. And then with the transplant, usually you get about a week of chemotherapy that really clears out your own bone marrow cells, like such as the progenitors of white blood cells. So, you know, you're kind of lacking any immune system there for a couple of weeks. And then you get the bone marrows infused in right after the chemotherapy. And then over about 2 weeks, you begin to see the beginning of these new white blood cells. And over the course of a year or two, they really kick in. But, you know, within a few weeks, you're back to having a reasonable immune system. And then within several months, 6 months, you know, it gets fairly okay again. So, you know, so kind of my thoughts a little bit are in general with bone marrow transplants is that, you know, the eczema and the infection, that for this disease should be cured or close to cured. Although if you have some of the lung disease findings, you know, that might be stabilized, but won't go away. But, you know, you do have this kind of infection risk around the transplant. And then there's other kind of downsides about transplants, such as, you know, seeing whether or not the donor gets along with your body, which is called graft versus host disease, and then other things like infertility. So for this disease, you know, it seems to make sense for some patients, you know, who are sicker, you know, because I mean, bone marrow transplant is not something people go into lightly. You know, there is a chance of dying from a bone marrow transplant. So we have transplanted 4 patients here at NIH, and around the world, it's been about 25 patients. And the 4 patients we transplanted were all kids or a very young adult, kind of all at the kind of worst end of the spectrum of the disease. And all are happy that they had their transplant and are doing quite well. And some great outcomes are being reported elsewhere. But, you know, it's not going to correct everything for this because a lot of the problems in this disease don't have anything to do with the bone marrow cells or the white blood cells. So we do think the infections get better. The bones, in terms of, I don't think it would affect scoliosis, but in terms of the fractures, I don't know. We have not seen that improve yet, but, you know, maybe we haven't waited long enough. The blood vessel changes we don't think will get better. And then, you know, we do worry about some of the healing issues, you know, that we don't expect. So for instance, if you got a pneumonia after your bone marrow transplant, I think still there might be some of those healing issues. Okay, and then I wanted to talk about, because this is a little more pertinent for the last few years, COVID-19 and these and our patients. So this is about my patients in general, our cohort here. So before vaccination, or without vaccination, you know, I think we were all really nervous because we have a lot of patients with really significant lung disease, and we didn't really know how that would turn out. And we had at least 13 people got sick from COVID before there was any vaccination. And this was early on. I mean, and for some of these people before we even knew how to treat COVID at all. And we had 5 people hospitalized, and some of those people were also hospitalized, just because of the risk of the underlying disease. And all 5 of those, though, had significant lung disease when they were hospitalized, and had other risk factors for severe COVID as well. And unfortunately, we had one patient, only one of our patients ever went to the ICU, and it was one death too. And that patient had a lot of other risk factors, had a prior heart attack, it was a very, very overwhelmed hospital at the time. Post vaccinations, we've had at least 26 and probably a lot more COVID infections. And we had 1 hospitalization. So it's really, really improved things in terms of, whether or not people are vaccinated or not. And that one, it's very unclear if it was really COVID or not, this pneumonia that she had, because it was more of a bacterial thing. And we haven't had any fatalities since then. And here's some of the chest CTs of our patients who've had COVID. And this is what the chest CTs look like before COVID. So I'm not doing it during COVID, but I'm just showing that these are people that have a lot of changes on their CTs. You can see a hole here and bronchiectasis and different holes in these lungs. And these patients all did it and did not end up in the hospital and did really fine. I worry about it and I give people antivirals like Paxlovid, but I don't have it. I'm just joking. Patients are doing so much better now after being vaccinated. So finally, just to kind of wrap up with some of our ongoing projects, we've been looking at the COVID vaccine responses, which have overall been quite good. People do need boosters because we do see kind of a decrease in antibodies over time, and it's important to get. And then we've been working with some of our international collaborators, a group that group that did a bunch of the transplant work. They have now gotten a bunch of sites from all over the world to work together to study quality of life for those with Hyper IgE syndrome. And then we can look at, well, what's the quality of life if someone got a bone marrow transplant? Or what's the quality of life change if someone's on dupilumab? Or, is it more from lung disease? Or, does IVIG help, for instance? So looking at the centers around the world, we're putting all the data together. And that's, I think already they have about 140 or so, 130 quality of life surveys that are already filled out for analysis. Then, as I said, I think we're really trying to understand better that healing in the lung. In Germany, they're doing some work about that, like trying to understand the healing in the lung. We're working with University of North Carolina about that to understand that a little bit better. And then, along with things like bone marrow transplant, people talk about gene therapy, and we think a little bit about gene editing. Is that possible? Is it possible to go in there and fix the mutation? So there's a few different centers working on that, and that's just a couple little ones I wanted to point out of projects that are going on kind of around the world to try to understand this disease better and try to make everyone better with it. So with that, I am happy to answer any of your questions. Thank you so much for listening.
Wonderful. Well, thank you so much, Dr. Freeman. That was awesome. All right, so I'm going to go ahead and reshare my slides. All right, here we go. And then now it's time for Q&A. All right, so first question for Dr. Freeman. What is usually the first indication that someone might have hyper IgE? Is it broken bones, chronic pneumonia, or maybe baby teeth not falling out?
That's a great question. So, our goal is to be able to diagnose this before we get to the point that we notice that the baby teeth aren't falling out, because that's not usually until people are like 7, 8, 9 years old. So, usually it's the rash, but the problem is that, babies can have rashes. So it's often not recognized in the newborn period, unless someone else in the family has had hyper IgE syndrome. So it's, it's passed from a parent half the time. So, I think it's the combination usually of having a rash and then pneumonias early in life. Most of our patients have had a pneumonia within the first few years of life, and that combination should really start making people look into it and lead to the diagnosis.
Wonderful, thank you. All right, next question. So you mentioned during your talk the different issues that patients with hyper IgE might experience, such as skin, bone, lung issues, etc. So I was wondering, can you give a couple examples of other clinicians that might be included in a patient's care team in addition to their immunologist?
Yeah, that's a great question. So, yeah, there's a lot of different types of doctors that our patients see. When our patients come to see us on our protocol, we have them see a dermatologist for some of the skincare, and I think a lot of people have seen dermatologists. People have seen allergists. Because some people have had food allergies. The other thing is a dentist, a good pediatric dentist, I think is really important. If there are trouble with broken bones, then we often involve an endocrinologist because sometimes we'll give bone building medications based on that. You know, with the flexible joints, sometimes people can have joint pain or kind of clumsiness. So sometimes we'll have people see physical therapy. Some of our patients get orthotics put in. So rehab doctors or physical therapists or occupational therapists can be really helpful for that. Pulmonologists for the individuals that actually have lung disease. Not all of our patients, do, when the ones sometimes with the earlier diagnosis, we try to prevent that, but as best we can, we can't always. Yeah, I think those are some of the most common ones. Now, orthopedics gets involved. Like if you have scoliosis, then you have to go see, an orthopedic, like a spine surgeon or for broken bones, but that's usually as it comes up.
Awesome, thank you. All right, next question. Do you foresee hyper IgE or other types of PI being included on the newborn screening panel like SCID is?
Yeah, that's a great question. I don't know, because in part, so, the newborn panel has been, a lot of it is focused on, there's like a couple different things, right? One is, how the actual diagnosis is made. So for SCID, for instance, it's usually by the TREX, like looking for that very low number of lymphocytes. But here, there's a lot of different mutations for STAT3. There's not like one thing that you're going to have in the blood spot where you're going to get that quick diagnosis that you get with SCID. The other thing is for SCID and some of the other newborn screen things, those are things that really need to be actionable within those first few weeks or first couple months of life, where it makes a huge difference. So we know with SCID, you got to get those babies to a bone marrow transplant or gene therapy or whatever type of transport enzyme for ADA, before they develop the infections, because otherwise it really changes the prognosis. So, and that's not as much the case here. So I think the combination of, the combination of both being, it's something that's going to be hard to sort out on a newborn like blood spot, as well as kind of how quickly it needs to be actionable, I think is the reason why it's not part of it right now. But in the future, I think whole exome sequencing is becoming so much more common, and you just wonder what will happen in the future. And then babies might be diagnosed with a bunch of different things quickly about that.
Thank you so much. We've definitely been getting a lot of questions of that type. So thank you to whoever asked. All right, next question. Um, this individual asks, Dr. Freeman, in regards to approach to care, would you say it's more patient-led or physician-led?
That's a good question too. I think, it's, I hate to make those distinctions, right? We try to be a team. I pulled up my questions, I know who, but too, I would hope some of it is physician-led, right? In that, when you're first diagnosed with that disease, you're not going to know about all those things, right? Like we're going to send someone to the dentist and be like, you need to hear about the baby teeth. And I would say that's, fairly physician-led. And some of the other things, like we do like to screen our patients for some of the vascular changes. And again, that's more physician-led. But, it really should be a team approach because, I think, most good doctors know, right? You're not going to make it very far unless you're listening to your patients and the symptoms that they're having. So, so it really has to be the team approach. And I think that's what's hard sometimes in this disease. Like when people don't know anything about this disease, it can be a little bit tricky when people don't know that the presentation is different. So I'm always trying to talk to local, doctors when my patients are sick or whatever to try to ease that some.
Thank you. All right, next question. You touched on gene therapy a little bit there at the end of your talk. So this individual asks, you spoke a lot about bone marrow transplant as a potential option for treatment, but what about gene therapy for hyper IgE?
Okay, so that's a good question. So I didn't talk about gene therapy really because I was talking about gene editing. So, and I didn't go into the details about all that, but so when you have, I guess people can see my hands, right? So the problem with gene therapy is really a lot easier if you just need to replace one gene. So in this disease, you have one normal copy of STAT3 and you have one copy of STAT3 that has one change. But the one that has the change is causing problems for the normal copy. So that's kind of it's a funny genetic thing that we call dominant negative. But because they stick together, the two copies, have to be in that pair to go into the nucleus. It really matters that you have the one there that's a problem. And with gene therapy, you're just giving additional copies of a good gene. So people with this disease already have that good copy. You really need to get rid of the bad copy. And that's why gene therapy isn't going to work for this disease. So that's why we think about gene editing, where you can really go in there and take out the mutation and try to fix it. Now, it won't be perfect for this. First of all, that's still a little bit like in the future, like, it's not mainstream now for, most things, because right now you can only correct so many of the cells. And for this disease, you'd really have to correct most of those white blood cells to make that work. Because again, you got to get rid of the one that's causing the problems. So that's why gene editing is a little tricky, but we're trying to see about what is feasible for gene editing. And I know there's places in Europe working on that. There's some people around here that are working on that to see if it's feasible. And that would be just for the white blood cell components and not for some of the other things like the bones or the connective tissue stuff. So I hope that made sense. My genetics 101.
Thank you. And it seems like maybe more to come on that topic, so we'll keep our eyes out. All right, so the final question is, once a patient with hyper IgE is pregnant, are you able to test if the condition will be passed down to their child? And if so, at what stage?
Okay, you can do that. In people that have a STAT3 mutation, they have a 50% chance of passing that on to their child. And you can figure that out through any genetic testing that's done on the fetus. You can do that with CBS, you can do that with amniocentesis. So those methods, or you can do that before, you can do that with in vitro fertilization. So you could take the egg or the sperm, you could take the fertilized eggs and try to figure out which ones have the STAT3 mutation or not. So it is possible to do that and then select for the embryos that don't have the mutation as well. So it's possible to do it pre-implantation or with things like CBS or amniocentesis. We personally can't do it because NIH is not like a research hospital. We're not, all those things have a little timely aspects to them, some of those things, and we don't do it here.
Wonderful. Well, thank you so much, Dr. Freeman. I think that's going to wrap up our Q&A. So just a couple more slides to get through, but we want to give a huge thank you to Dr. Freeman for her wonderful presentation. And thank you to our audience as well for a great Q&A.
Thank you so much again for having me.
Sure thing. It was a pleasure. So just really quick, we hope that you'll take advantage of all of the resources that IDF has to offer. To find our materials on Hyper IgE, again, you can go to primaryimmune.org and just search Hyper IgE in the search bar. Or visit the IDF Resource Center, where we have educational videos of all of our past presentations. We have countless resources, as well as opportunities for connection within the PI community. And to our audience, if you have additional questions, you can ask IDF, go online and visit Ask IDF at www.primaryimmune.org/ask-IDF, or you can also give us a call at the number on your screen. We want to close by saying that all IDF programming is truly guided by the needs of the PI community, and we hope you will let us know if you like today's program by filling out our evaluation survey, which will be sent out to all participants after the webinar. And lastly, here's a preview of our upcoming programs in the next few weeks. Our next IDF Lunch and Learn will be on November 9th with Dr. Kelly Walkovich, who will be presenting on NEMO. And then the following week on November 16th, we have a Skid Compass Lunch and Learn on organ function and long-term follow-up outcomes with Dr. Ami Shah. So, Dr. Freeman, thank you again so much for being a part of today's program. It was wonderful. And thank you so much, everyone, for joining us. We hope you have a wonderful rest of your day. Take care.
Thank you.
Thank you.